Okay, good morning everyone. So I have absolutely no conflict of interest to declare. Sometimes I wish I had, but I don't have any. Critical illness, today we are going to go back to a little bit of basics and then we're going to work it up. So let's just go back to what is critical illness. So it actually refers to a wide range of life-threatening medical trauma or surgical conditions, and it usually requires some sort of intensive or critical care. Okay, and critically ill patients often exhibit at least one single organ dysfunction that is severe and that necessitates active therapeutic support or intervention. So what is an intensive care unit? So in 2016, the World Federation of Societies of Critical Care Societies came together, and it's actually a 16-page document. It's very interesting to read through, and they compiled this very short and precise definition of what an intensive care is. And it's an organized system for the provision of care to critically ill patients that provides intensive and specialized medical care. So it's not your usual medical care, it's highly specialized care that's provided to these patients, as well as the nursing care. An enhanced capacity for monitoring and multiple modalities of physiological organ support to sustain life during a period of acute organ system insufficiency. And although an ICU is based in a defined geographical area, often its activities extend beyond the walls of the ICU, and that's a follow-up clinic, a hospital ward, etc. So terminology, for many, many years, I don't know, I've been qualified for over 2 decades. And it was a huge thing when we started talking about artificial nutrition support. And it's artificial nutrition support, and I think it made dietitians feel very important, if you can say artificial nutrition support. But we are moving away from that term, and we are now looking at using the term medical nutrition therapy. Also in Britain, they've published a document called Clinically Assisted Nutrition and Hydration Towards the End of Life. They're now talking in terms of that term. And previously, it was seen as a standalone adjunctive type of therapy. Nobody really worried about the nutrition support side of things. But nowadays we know it is part and parcel of the ICU management of a patient. And that is why we refer to it as medical nutrition therapy. So what I'm going to do is I'm just going to go back to basics now, because I know you all have different backgrounds, and we're going to look a little bit at the pathophysiology of critical illness and then the different metabolisms of carbohydrates, lipids and fats, just to revisit what some of us has maybe done many, many years ago. Okay, so some critically ill conditions are actually associated with an infectious organism, and that can cause sepsis and infection. But some categories are not associated with an infectious organism, but it also counts as a critical illness condition, and that's your burns, severe trauma, your post-operative state, pancreatitis, hemorrhage or ischemia. Now, the American College of Chest Physicians sepsis definition is it's a life-threatening organ dysfunction caused by dysregulated host response to infection. So, SIRS describes the complex physiological response that actually takes place after an insult or an injury to the body, such as infection, trauma, burns, or pancreatitis. And then you get the systemic inflammatory response syndrome. So critical illness is catabolic, it's life-threatening, it is created by overwhelming infection or trauma, or by things like severe tissue injury, like after a motor vehicle accident, or pancreatitis. So the initial reaction to critical illness from the host is actually at the site of the injury or the infection, where that. And then you get cellular activation of monocytes, macrophages, and neutrophils at the vascular endothelium. So this is followed by the activation of the complement system, and it leads to vasodilation and also increased capillary permeability. And the increased permeability leads to sequestration of interstitial fluids and the release of chemoattractants. And then additional macrophages are recruited, and it enhances the inflammatory response by phagocytic activity. Okay, so the response is also supported by several cytokines, and we know these cytokines are very pro-inflammatory. Most of you must have heard of tumor necrosis factor, TNF, interleukin 1, 2, and 6, interferons, and then there's other multiple pro-inflammatory cytokinins. So once there's a high level of these cytokinins that reach in the body, when the level ups and ups and ups, you actually get them released into the systemic circulation. And then you present with the typical signs and symptoms of the systemic inflammatory response syndrome. So although in some circles it's phasing out the terminology, we are still talking about the ebb and the flow phase of critical illness. So the ebb phase is very quickly within the first 24 to 48 hours, and it's when the patient is hemodynamic very unstable, reduced oxygen consumption, low body core temperature, and elevated glucagon, catecholamines, and free fatty acids. Some of them are our stress hormones. Now the flow phase follows the ebb phase. It's a few days later on, and then you get increased total body oxygen consumption, increased metabolic rate, your cardiac output increase, and then increased oxidation of fuel sources like your carbohydrates, your amino acids, and also your fats. Okay, so the severity of the insult or the actual injury will correlate with the rise in your energy expenditure. So there will be increased metabolic demands lead to breakdown of lean body mass. So the more severe the injury, the more severe the breakdown of the lean body mass. So the ebb phase is a pro-inflammatory phase, unfortunately, but it's also there to help fight infection and to provide substrates for healing during the inflammatory response. Occasionally, the pro-inflammatory phase can be severe and very damaging to the host, and then the anti-inflammatory response that follows that counterbalance the pro-inflammatory state. Okay, so if we look at carbohydrate metabolism, hyperglycemia and insulin resistance is very common in critical illness. We see that all the time. I see it every day in my daily practice. So you get these pro-inflammatory cytokines that's released of the catabolic hormones, and those are your glucagon, your catecholamines, and your cortisol. So it stimulates glycogenolysis and glyconeogenesis in the liver. And for those that can't remember what those is, okay, so glycogenolysis is the biochemical breakdown of glycogen to glucose, and your glyconeogenesis is the generation of glucose from non-carbohydrate substrates such as your amino acids, for example. And then above, mobilize glucose for utilization by the cells that require glucose as the primary fuel source, because during the first few days of your critical illness, glucose is the preferred fuel source, and also for your central nervous system cells and your inflammatory cells. So glycogen stores are depleted within hours. Endogenous fat and protein become then your major source of energy substrate, and protein via gluconeogenesis is converted to glucose. Right, we've looked at that term. The glycerol moiety of fat, that's the triacyl glycerol, can convert to glucose. But unfortunately, the triacyl site cannot convert to glucose because the human body doesn't actually have the enzymatic pathway for that to take place. So therefore, during critical illness, you rather get this large-scale degradation of protein in the absence of endogenous sources of your glucose that is supposed to take place. So hyperglycemia can also caused by your increased endogenous glucose production, decreased glucose uptake and insulin resistance. In some patients, the endogenous production of glucose can reach up to 300 to 400 grams of glucose a day from endogenous. That means from within the body, which the body is actually producing itself. Right, so protein metabolism. It's the main source of substrate during the catabolic phase of critical illness. We will touch on it later on, but you need to differentiate between hypermetabolic and hypercatabolic. All right. So there's a difference between the two. In the beginning, it is hypercatabolic. So that means breakdown. There's an increased breakdown, not necessarily an increase in the hypermetabolism. So the human body doesn't have reserves protein. All of our proteins actually serve a structural or a functional property. And then we use labile amino acids that comes from skeletal muscle, the gastrointestinal tract, connective tissue, and the protein in the skeletal muscle is rapidly metabolized. And that is in response to increased demand after injury or acute inflammatory illness. And if it continues, you get this net protein negative balance and loss of lean body mass. And unfortunately, it leads to organ dysfunction and a poorer outcome. So protein is degraded for gluconeogenesis. As I said, that is to produce glucose from non-glucose sources. Increased turnover of the nitrogen from the body, and your nitrogen balance is obviously the protein that you take in minus the nitrogen that you excrete. So critically ill patients are mostly in the beginning phases are in a net negative balance. Amino acids are released by the muscle directed to the liver, and then ureagenesis takes place, and the synthesis of creatinine, uric acid, and ammonia is then formed. So the increased amino acid efflux from peripheral sources provides a substrate for enhanced hepatic gluconeogenesis, and then the formation of your acute phase response proteins like your CRP, your albumin, your prealbumin, and this is known as hepatic reprioritization. So if we look at critical illness, protein catabolism is the typical hallmark of your critical illness. And this process needs to manipulate it because you can't stop it. Doesn't matter what you do, you're not going to stop it. It's part and parcel of the whole critical illness process that starts to take place. So if we look at protein catabolism again, so patients with sepsis or critical illness, they show an accelerated release of these amino acids. And then these amino acids, that is an increased level that is released from skeletal muscle is taken up by the liver and other visceral organs. And then sufficient amino acids are then available to synthesize proteins for your immunological defense and healing. So your skeletal muscle, amino acid uptake is reduced, protein synthesis reduced, protein breakdown increased. Amino acids then goes to the liver, where you have increased amino acid uptake, protein synthesis, and then your acute phase protein synthesis that also takes place. So if we look at fat metabolism, early on in your critical illness, carbohydrate is actually the preferred source for energy. But converting fats to ATP requires a lot of oxygen and well-functioning mitochondria. And during critical illness, both of these are actually impaired. A lot of mitochondrial cells in patients that suffers from critical illness are not functioning as they should. Okay, so stress hormones then stimulate lipase, and it leads to hydrolysis of your triglycerides, and it's released as free fatty acids and glycerol into the bloodstream. And the ability of cells to transport these long-chain fatty acids are actually impaired from the cytosol to the mitochondrial. And then this leads to an accumulation of the free fatty acids into the cells, and it inhibits the function of pyruvate dehydrogenase. Okay? And this leads to an accumulation of pyruvate into the cells, and then lactate and other intracellular acidosis can actually start to take place within the cells. This whole process cause a decrease in aerobic respiration and the cell's ability to utilize the Krebs cycle for energy production. So later on in critical illness, the free fatty acids, so oxidation can occur in the peripheral tissues. And in the liver, they converted to ketone bodies or re-esterified to triglycerides, and then they delivered into the bloodstream as very low density proteins or lipoproteins. So overall, the metabolism of fats is increased, but complete oxidation can only take place in those cells that has intact and well-functioning mitochondria. And during critical illness, many cells and tissues unfortunately have dysfunctional mitochondria. So actually, the oxidation of fats doesn't take place properly during the first phases of critical illness. So critical illness causes many stress factors that actually induce cellular damage, all right? And this can lead to organ failure. We know this by now. And autophagy is a crucial repair process essential to the recovery from this critically illness organ damage that takes place. So autophagy basically means self-eating. It's a catabolic process, and then the intracellular content is delivered via an intermediate organelle, which is called the autophagosome. Okay, and then they mature. These autophagosomes, they mature, and then they fuse with the lysosomes, after which the engulfed content is degraded and recycled. So it actually saves the cell from damage, right? So autophagy can also damage cellular proteins and organelles. So on the one side, it helps, but on the other side, it can also cause damage, okay? And this could contribute to the risk of non-resolving multiple organ dysfunction and adverse outcome. So this is why you get a percentage of patients in ICU that despite all the interventions, you get one patient with multiple organ dysfunction that leaves the ICU, and then you get certain patients that are not leaving the ICU because of an aggravated or an overwhelming autophagy response. Okay, so autophagy is actually the pathway for clearing damage. Now, human and animal studies have shown that the liver and skeletal muscle of critically ill patients have a phenotype of deficient autophagy. Now, if we look at this slide, this is what I was referring to, why it actually makes it very confusing. So you have stimulation and you have the inhibition of autophagy. So starvation, glucagon, oxidative stress, glutamine, rapamycin, and then correct hyperglycemia can all stimulate autophagy, which is actually positive. We do want that cell clearance of all that bad things that's happening. But feeding, insulin, excess nutrients, mTOR, and hyperglycemia can inhibit autophagy. Does that mean we shouldn't feed, we shouldn't be using insulin, or that hyperglycemia is a problem? Of course. So does that mean we should not feed patients because of autophagy so that it can take place? So insufficient autophagy with more pronounced mitochondrial abnormalities in your hyperglycemic liver suggests direct mitochondrial damage by hyperglycemia. So it is bad for the body if there is hyperglycemia. Okay, this can be prevented by maintaining normoglycemia with insulin. This benefit could partly be counteracted by suppressive insulin effects on autophagy. Okay, so you see how it's contradicting one another. Remember, excessive autophagy can cause cell death, but if you have, on the other hand, controlled autophagy, it can be protective by providing essential substrates during nutrient deprivation and by removing the damaged molecules and organelles. So really, we don't have evidence yet to withhold nutrients to allow autophagy. The autophagy is going to take place. If you start feeding slowly, you don't put liters and liters and liters of feed in the first 24 hours, then you're not going to have excessive, and you're going to control the autophagy. And you should correct the hyperglycemia with insulin. If you don't do that, then it can lead to excessive autophagy. Okay, so it's important to address the hyperglycemia with insulin, even though that sounds contradictory. Okay, if you want to, this is a very nice article to read. I'm not going to discuss it, but it's insufficient activation of autophagy allows cellular damage to accumulate in critically ill patients. And they explain very nicely why some patients move on to develop autophagy in excess, in others not, and what happens in the skeletal muscle and in the liver. Okay, very nice article to read. Now we get to Albert, the nutrition assessment and screening. So the purpose of nutritional screening is to predict the probability of a better or a worse outcome due to nutritional factors, and whether the nutritional treatment is likely to make a difference or not, or whether to influence this. So in ICU, really there's only two nutritional screening tools that we should be using, and that is the NRS 2002 and the Nutrix score in ICU. There's a lot of other tools like the mini assessment tool, the MUST tool, but they have not been validated to be used in ICU. And what makes these two tools slightly different is that they don't just screen nutrition status, they actually screen disease severity as well. Okay, so you screen the patient's nutritional status and disease severity, whereas with all the other nutritional tools, you actually only screen the nutritional status of the patient. This is your Nutrix score, and it just takes into account things like age, Apache 2, which is a system that we use in ICU, SOFA scores, number of comorbidities. Now, what they have actually added here is interleukin 6. We don't have access to that routinely in our units. So what they say, you can use this nutrition score. It has been validated to use in ICU whether you have access to the interleukin-6 value or not. It does not make it less accurate if you don't have the interleukin-6. Okay. This is the nutrition risk. Sorry, it's very unclear. But personally, I think we should use the Nutric score because it has been validated for use in the ICU population. So the nutritional assessment of the patient is very subjective because a lot of our traditional parameters are not available or they're completely subjective. For example, anthropometry is not suitable in ICU conditions. But factors to consider is the underlying diagnosis and comorbid factors. How many patients, for example, with irritable bowel syndrome come into the ICU and then we don't even know about that, and then later on we can't understand why these patients are suffering from diarrhea. Mode of ventilation, is this patient breathing spontaneously? Are they triggering the ventilation? Are the machine breathing entirely for themselves? All these things will affect resting energy. The degree of sedation, the presence of SIRS or sepsis, pyrexia, drugs, renal replacement therapy, where there can be a lot of losses. I don't discuss this today on its own because I don't have time. But traditionally, dietitians will say if a patient is on hemodialysis, they will increase the nitrogen or the amount of protein rapidly. Now, that's actually not correct because you get different modalities now of renal replacement therapy. You get your normal standard dialysis, and then you get your ultrafiltration, your CVV-HDF. If you add dialysis with ultrafiltration, then you have huge losses of amino acids. So you need to look at the mode of dialysis or ultrafiltration that the patient is on. Okay. Biochemistry, it's a huge part of assessing the patient in ICU. Fluid balance, and we know that 60 to 70% of patients suffer gastrointestinal intolerances in ICU. So calculating requirements. I've had a lot of young dietitians working with me. I also get students from UP, and they always want to know, what do you do? What do you do? How do you do it? They're just so excited. They just want to calculate requirements. We are not calculating. We are guesstimating. All right. We really can spend hours on calculating and still get it wrong. So what I suggest is that you review and critically appraise the literature on a regular basis. And we know that indirect calorimetry is the most accurate assessment. All the guidelines worldwide says that is the only gold standard, okay? And I think in the teaching academic hospitals, they actually have access to that. I don't have access to that. Now, the method is restricted in some hospitals. So there's two articles. They are a bit older, but I've read them both, and they give you a very nice view on how to calculate the requirements of ICU patients. So if you have time, I would really, and it's both for critically ill patients, I would spend some time reading these articles as well. And after you've read them, they actually say that we should use the Penn State, the Eaton-Jones, the Swinelmer, but no single prediction equation is 100%, unfortunately, we know that. Double check with more than one formula if you're in doubt. You must feel comfortable with the formula. Don't use a formula that is difficult and time consuming if you have, like myself, 20 or 30 patients that you need to see. And spend your precious time monitoring your patients, because you can calculate for 2 hours and still get it wrong, and by tomorrow you have to change it anyway. So rather go tomorrow and see what's happening to the patient and then change it on a daily basis, rather than spending hours and hours on every patient calculating. Yes, we have to calculate, but we shouldn't waste time on calculating. What weight to use? I'm sure this is also a question that we get quite a lot. Okay. Where possible, actual body weight. Okay? In the obese patient, you determine actual, usual, and ideal body weight. Now, this is also in the ESPEN guidelines. I still get dietitians using adjusted body weight. Now, I've worked in the UK for 10 years, and in 10 years we were told never ever to use adjusted body weight. Why? There's no validation studies done on it. There's no good literature on it. And dietitians all over South Africa are still using adjusted body weight every single day. So please tell your dietitians we should not be using adjusted body weight. There's differences in the definitions in the literature. There's no good validation studies. and there's even adjusted body weight formulations, but it's inaccurate. Okay, we shouldn't be using it. Ideal body weight, usual weight, or actual body weight. Okay, that's very important. So what do the guidelines recommend? We have to look at the guidelines. I know it's only guidelines, but if you look at the amount of studies that they have used to compile these guidelines, it's actually thousands and thousands of studies, and none of us is going to read through all those studies and reinvent the wheel. So the ESPEN guidelines, they reiterate the fact that indirect calorimetry is the standard for energy. If that's unavailable, you use a published predictive equation, which I've just said, or a weight-based, for example, 25 to 30 kilocalories per kilogram per day. There will be exceptions to that, and we will get to that in a minute. Protein, weight-based equation of 1.2 to 2.0 gram per kilogram, actual body weight, and it can be higher in burn or trauma patients. So we all know it's not easy to get to 2 grams per kilogram protein body weight. That is a challenge for a lot of us. The ESPEN guidelines, they actually say 1.3 grams per kilogram, and then carbohydrate should not exceed 5 milligrams per kilogram per minute. So they actually don't say it, but they refer to the glucose oxidation rate. Now, some literature will say 4 to 7, but ESPEN actually says 3 to 5. So what you do is you calculate it. Okay, 3 to 5 milligrams per kilogram, and that's the amount of minutes that you find in 24 hours. Okay, 1,440. You divide it by 1,000, and then you get the amount for a specific patient that they should be able to oxidize safely in that day. So for some patients, it will be 300 grams of glucose or carbohydrate. For some patients, it will be nearer to 400. Okay. If you are exceeding the glucose oxidation rate, it's stored as glycogen, but glycogen storage capacity is not unlimited, and then large intakes of greater than 500 grams may result in lipid synthesis, which we don't want in patients' fatty livers. So the average tube feed is unlikely to exceed your glucose oxidation rate, but don't assume. Calculate if in doubt. Calculate if you're on IV containing dextrose fluids. Calculate especially if you're on parental nutrition and enteral nutrition. I mean, some parental nutrition bags contains up to 300 grams of glucose, which is rather a lot. Your extremes of patients, very underweight or obese. And then we don't want additional CO2 production because you're exceeding glucose oxidation rate. But your excess production of CO2 can start below the glucose oxidation rate. So if you see this trend where the CO2 is just increasing and increasing for no particular reason, then go and have a look at your glucose oxidation rate. So when to start and why? We're going to screen patients. Then high-risk patients, according to the guidelines, are most likely to benefit from early enteral nutrition. ESPEN says within 24 to 48 hours in critically ill patients, and we use EN over PN where indicated. If your patient is severely malnourished, if you've done a screening, you cannot feed enterally, then you start parenteral nutrition as soon as possible. Okay, how much depends on individual patient factors. So this, I found it difficult to summarize it, so I'm going to read it. This is the part where they actually say from the ESPEN guidelines why we should feed enterally. And once you've read this, I can't find any evidence why we shouldn't start feeding patients enterally. So EN supports the functional integrity of the gut by maintaining the tight junctions between the intraepithelial cells. It stimulates the blood flow and inducing the release of trophic endogenous agents. EN maintains structural integrity by maintaining villus height and supporting the mass of secretory IgA producing immunocytes, which is your B cells and your plasma cells, that compose the gut-associated lymphoid tissue. We commonly know that as GALT, and in turn contribute to mucosal-associated lymphoid tissue at distant sites such as the lungs, liver, and kidneys. So it also affects those organs if you start feeding early. Adverse changes in gut permeability from loss of functional integrity is a dynamic phenomenon that is time-dependent, and the channels open within hours of the major insult or injury. So the consequence of the permeability changes include increased bacterial challenge. So it's the engagement of the GALT with enteric organisms, which we really don't want to take place. The risk for systemic infection and greater likelihood of multiple organ dysfunction syndrome. just by not starting to feed the patient early, you can actually put your patient in multiple organ dysfunction syndrome. Isn't that scary? Okay, as disease severity worsens, increase in gut permeability are amplified, and the enteral route of feeding is more likely to favorably impact outcome parameters of infection, organ failure, and hospital length of stay. The specific reasons for providing EN are to maintain gut integrity, modulate stress, and the systemic immune response, and attenuate disease severity. Additional endpoints of EN therapy may include the use of the gut as a conduit for delivering of immune modulating agents and use of enteral formulations as an effective means for stress ulcer prophylaxis. So there's overwhelming reasons and overwhelming support to start enteral nutrition early. Okay, and we have 24 hours to do that, 24 to 48 hours. Now this is a topic that I wish I can talk to everyone about. It's gastric residual volumes. Okay. And there's a lot of debate about this, and I'm going to try and make a point today so that I can win the debate. Okay. Let's have a look at it. So a long habit of not thinking a thing wrong gives it a superficial appearance of being right. So for 20 years you are a nurse in ICU, and the protocol says you're going to aspirate every 4 hours. You've never thought why you're doing it. You just do it. You follow the protocol. But maybe somewhere along the line, you're not doing the right thing. But because you've been doing it for so long, it gives you the appearance that it is actually the right thing to do. Okay. Now, if you go and you take nursing textbooks from, let's say, 20, 30, and 40 years ago, the origin of the concept of aspirating GRVs is difficult to trace. It's difficult to trace where they started to aspirate gastric residual volumes. Okay, if you can find it, please send it to me. I will appreciate it. There's no foundation of clinical data or formalized studies that actually exist on this. So if you are a believer that you should aspirate every 4 to 6 hours or every 8 hours in your unit, you presume that aspirating the gastric residual volumes will help to distinguish normal and abnormal gastric emptying. That's what you believe. You assume that the accumulation of the enteral nutrition in the stomach leads to aspiration. So that's what you believe. That's why you do it. That's why we spend thousands, millions in nursing time and syringes to do this. And the aspiration of the gastric content invariably leads to aspiration pneumonia. Okay. However, there's very little scientific data to support any of the above, but yet we still do it, and we firmly believe it. I work with doctors that will say, Elize, we are not going to stop doing it. We are going to aspirate, end of story. Okay. So your gastric residual volumes are affected by your endogenous secretions, your gastric emptying, your positional effects. I'm going to show you a picture of the cascade effect, and then the exogenous sources, so what you're actually giving the patient. But you must consider both, your endogenous and your exogenous sources. Now, in a normal person like us sitting here, 4 to 5 liters of saliva and of gastric contents actually pass through the gastrointestinal tract. That is a lot. That is a lot of fluid that actually pass. Okay. But in ICU, it's different because they are tube fed, they can't smell, taste, or eat, so they produce less saliva. Okay? Often the patients are unconscious, they are on PPIs. Okay? So it reduces the total volume of gastric secretions, and then there can be distal feeding in the GI tract below the ligament of Treitz, and that might result in lower gastric and pancreatic secretions. So the total gastric volume in the ICU tube feed patient is very difficult to establish, and we don't know how much that is in correspondence to a normal person. But there are research methods, and they are looking at it, like paracetamol absorption, breath test, and basically it is slightly less than it is in a normal person. So if you look at gastric emptying of solids, it is at a fixed rate from the stomach to the small bowel. But with your fluids, which we often administer to these patients, there's a rapid emptying which slows down and then it tapers down. So the final amount of liquid is emptied at a slower rate. Okay, so there's not a steady rate of emptying of your liquids from the stomach to the small bowel. Now, all aspects of gastric emptying are affected by critical illness, and that's like your hyperglycemia, sepsis, and narcotic effects. Upper digestive tract intolerance to your EN is multifactorial. We know that the lower esophageal and the gastroduodenal motor responses are altered in critical ill patients, and that delays your gastric emptying. And there's adverse effects of sedatives, like, for example, certain drugs. Okay. That can also be considered a key reason in why the stomach doesn't empty very well. So, the position of the patient can affect the location and the volume of the liquid in the stomach, right? And this is where I'm going to prove people wrong that actually use gastric residual volumes. So, if you have faith in the practice of taking aspirates or gastric residual volumes, you believe that the liquid content of the stomach pulled together in a single volume, and that the tip of the feeding tube is positioned in that feeding volume, and that the entire stomach contents can be aspirated every 4 hours. But patients on their back in the supine position may allow the stomach to cascade or drape over the spine. So they lie on their back and their stomach actually split in two. All right. And then it causes the stomach fluid to potentially split into separate pools. So this can lead to less accurate gastric residual volumes, because if the stomach decides, let's move to the next slide. Say, for example, the stomach splits there and all the volume lies there, or all the volume lies there, and you're aspirating here or there, and you get zero. What was the point if there is 300 or 400 milliliters of fluid lying there in the stomach? Okay, so it's actually a very unscientific way of determining the gastric residual volume. Okay, so it can also be, now I don't know what size tubes you use in your units, but you get different Frenches, like 8, 10, 12, 14, 16, but you also get different makes of tubes. And the inside of the tube is not always the same size. So it's not about the diameter on the outside, it's about the diameter on the inside. This is not Ralph's tubes. Ralph's tubes is just a thick tube and everything comes through it. Also the size of the syringe, the timing and manner of aspiration, and patient position. So clinicians still believe in the tight correlation between aspiration and then gastric residual volumes, or elevated GRVs. So 5 studies randomized patients to different cutoffs provided no data to support the assumption that lowering the cutoff will lower the risk of aspiration. Now, I know some of these studies are a bit older, but none of them could find a relationship between an increase in aspiration or pneumonia, for example, and increased gastric residual volumes. No, there's no evidence of that. So you must just assess practices in your unit, be familiarized with up-to-date literature, assess mouth care practices, because you can aspirate on poor mouth care, on secretions in your mouth. You know, that's why we use chlorhexidine in our units. Establish the size of the feeding tube used, establish the size of the syringe, assess the position of the patient, and then also look for other signs and symptoms. I mean, if a patient is suffering nausea, vomiting, they're constipated, they have abdominal distension, maybe then I'm going to have a different view if we aspirate 500 or 600 mL from that stomach. But the actual recommendation says from ESPEN that GRV should not be used as part of the routine care to monitor for aspiration. They actually confirm what I've just said. And then for those ICUs where it's still used, a volume less than 500 mL shouldn't be used as a cutoff in the absence of other signs of intoleration. Okay, so if you're still working in a unit where they're using 150 or 250 milliliters, that's very old practice. Okay, and ESPEN also says GRVs do not correlate with the incidences of pneumonia, regurgitation, or aspiration. All right, I'm sure you've heard and read this very famous article. I quite like it. It's tailoring nutrition therapy to illness and recovery. And I just quickly want to go through it because I believe what they say in this study is what's actually happening in a lot of our units. So they described the Minnesota starvation study, which nowadays will not get ethical approval. Okay, so in Europe, people lived on little bits of bread and potatoes during the World War II, and they became emaciated and they were very thin. So this very ambitious professor, he set out to assess how civilians will do on a starvation diet and then a post-war or a post-starvation nutrition rehabilitation program. They enrolled 36 subjects. They started 3 months on 3,200 calories. They did extensive tests throughout on these patients, cognitive, physiological, physical, and then it was followed by a 6-month starvation diet of 1,800 calories and 0.7 to 0.9 grams protein per kilogram per day. So that was considered a low protein diet. And initially the subjects consumed only 23 kilocalories per kilogram per day and 0.7 grams of protein. But the weight loss was too sudden, and then they increased it to 30 calories per day and 0.9 grams of protein per day. So the participants actually developed all the signs of protein energy malnutrition. Fatigue, depression, anxiety set in. They started cheating. They started thinking and dreaming about food. And then one of the participants actually became so severely and neurologically unstable that they had to dismiss him from the study. They admitted him to the psychiatric ward, and then after a few days on a normal diet, he was 100% neurologically stable again. Okay, so after 6 months, the men lost almost 25% of their body weight. That's quite a lot. Their heart rates slowed down, their heart shrunk, and then the nutritional rehabilitation phase starts. Okay, so they received between an additional 400 to 1,600 kilocalories per day, but it didn't improve the starvation state. Then they added an additional 800 kilocalories per day. So they received 3,000 to 4,200 calories a day, and then it started to lead to weight gain. So in these men, it took them between 6 months to 2 years to actually come back to their normal weights. But the participants didn't suffer any long-term effects. Okay, and this is how they looked on the starvation diet. Now, if a patient like that comes into my ICU, I will be very worried if they look like that, and certainly I will prioritize them. The WHO recommends for a 70 kilogram person between 30 to 60 years for females and males. For males, it's 3,000 calories per day. For females, it's 2,500 calories per day, and a minimum of 0.75 grams protein per kilogram per day to prevent starvation. Now, in critical illness, if you look at the nutrition day, that is where they collate all the information around the world on a single day about critical illness practices around the world, they found that the average delivery of calories is 1,063 kilocalories and 0.6 grams of protein per day. That is what we are currently now in 2019, 2018, the results delivering to our patients. Compare this to what the actual recommendations for a healthy person is. Okay, so the metabolic demands can change significantly during the course of your critical illness, and the initial phase of your critical illness is not hypermetabolic, but it's hypercatabolic. So during the acute phase, there's drastic mobilization of calories, such as muscle glycogen and lipid stores to drive glucose production, and it can provide the initial stress response up to 50 to 75% of your glucose that you actually need from that response. But that's not affected by IV administration of glucose or feeding. What's important to notice here is that the initial status of severe septic shock doesn't lead to an increase in calories. Yes, hypercatabolic, drastic degradation of your lean body mass, but not necessarily your total energy requirements. Your total energy requirements actually stays more or less the same as a normal person. However, that will drastically change over the course of the critical illness, and it's more important to meet calories or protein, which is more important. So there are some famous studies that's been published on cumulative energy deficits in the ICU and the poorer outcome. And we're now looking back on those studies and asking, was it the calorie deficit or was it the protein deficit that was the problem? Okay. Now, the study that was done by Nicolo in 2016, they actually found that achieving more than 80% on day 4 and day 12 of your ICU stay decreased mortality by 60 days. But by meeting your energy requirements, it didn't really make a difference on mortality. So the ICU experts are now saying it's simply not good enough to get a patient out of ICU. We want quality of life studies to look at patients beyond ICU. Okay, so hypocaloric feeding during the acute phase is not applicable to malnourished patients though, because they don't have endogenous reserves to actually generate the glucose that they need. Okay, so in malnourished and high-risk patients where your enteral nutrition cannot start, you're going to revert to parenteral nutrition. During the recovery phase, the energy and protein needs to increase. And many ICU patients actually suffer the similar starvation than in the Minnesota starvation study. And that means they need up to 4,000 to 5,000 kilocalories per day. But can they actually consume that? And the answer is that no, I didn't know how many dietitians are actually giving 5,000 kilocalories in the recovery phase to patients that we have starved in the ICU. And maybe it is something we need to start looking at and changing our perceptions, that start slowly but gradually build it up and then end up much higher than we are currently delivering. And we might see a difference in 6 months and 2 years and 18 months of these patients. So because these patients have very difficulty to consume that, I like this quote here. To address this, a large body of data demonstrates that oral nutritional supplements must become fundamental in our post-ICU and hospital discharge care plan. So you cannot send the patient home without discussing or at least mentioning about oral nutritional supplements. So Wishmeyer says the future, we're not there yet, but anabolic anticatabolic agents such as the HMBs, targeted nutrition delivery with the focus on protein, exercise, vitamin D to reduce that patients that are suffering mortality due to a vitamin D deficiency, and they also talk about thiamine. And this I've just put in because this is what he's proposed, and it basically, what we're doing now in some units is this, we're just doing that, but this shows us that we must tailor towards individual patients. Drug-nutrient interactions. I just quickly want to say here that your type of interaction can be at the absorption site, post-absorption, or elimination. And then I want to get to the next slide here. So enteral use of drugs and interactions with nutrients, there's in daily feeding practice. Now, I'm going to be honest that some of this we don't do. And maybe I should go back to the unit and talk to the doctors because there's practicalities around this that makes it very difficult. So you need to know the knowledge of type of the location of the feeding tube. Okay, that obviously I will know. The stomach is the choice for drugs that acts on this site, such as your antacids and ketoconazole. Your duodenum is preferably the route for drugs susceptible to gastric acidity. But how many of patients that get digoxin, carbamazepine, ciprofloxacin, and tetracycline actually also have these given into a nasogastric tube? Okay. Drugs that alter nutrients, so diuretics, can be hypo or hyponatremia, hypokalemia, dehydration, steroids, changes in sodium, potassium, and glucose, angiotensin converting inhibitors, hyperkalemia. We don't often think of that if a patient is suffering hyperkalemia, that it can be a medication. We will think about other reasons, maybe kidneys or whatever. And ferrotericin B, hyperkalemia and hypomagnesia, calcium supplements, which we often give, hypophosphatemia, and nutrients that affect drugs. I'm going to talk about phenetin in a minute. The quinolones reduce serum levels when administered with food. Itraconazole, increased absorption with nutrients. So if you give that with nutrients, then there's increased absorption. Warfarin, we know it's decreased anticoagulation with vitamin K, and alendronate, decreased absorption with food. So it's very important that the dietitian needs to stay up to date with drug-nutrient interactions. And I think as you get older, you forget these interactions. I just want to highlight one or two things here, and that is do not mix drugs and nutrients. Breaks should be determined, and dilute viscous or hyperosmolar solutions, and wherever possible choose gastric tubes. And this one is important, crushing of slow release tablets. Why is it a slow release tablet? Then we crush it and we administer it through the tube, okay? Then we actually defy the purpose completely. So propofol, Propaven, Diprivan is an additional source of lipid. Now usually if it's in small amounts, don't actually take that into account. But if it's in large amounts, like in all our trauma ICU, patients can be on up to 40 milliliters per hour of the 1%. And then, like you've mentioned in the previous talk, I'll ask for 2% because there's a risk of fat overload and hyperlipidemia, and it can delay gastric emptying. Then your anticonvulsants like Epilim and Epineutin. Epilim is not a problem, but with Epineutin, the absorption can be affected by enteral nutrition by up to 70%. So if your patient is on enteral Epineutin, you need to stop the feeding 2 hours before and 2 hours afterwards. So that means if it's a BD dose, you're missing out on 8 hours of feeding. So what you need to do is to ask your doctor if you can switch to the IV solution, because that's not affected. Okay, there's many different subsets of critically ill patients, but the obese need special attention because it's a growing population, literally and figuratively. Okay. So obese patients have different metabolic response to critical illness. They are not quite the same as our lean counterparts. Now, we would normally think that they use their fat as an energy source, but actually they have difficulty in using their fat as an energy source. So they mobilize more protein than fat due to a block in lipolysis and fat oxidation. And then that leads to unnoticed, because you have this very big person, you don't notice that they're actually degrading huge amounts of lean body mass and that they actually become very weak. Okay. They're also prone to insulin resistance that leads to hyperglycemia. Then they suffer hyperglycemia, and the hyperglycemia then causes the release of inflammatory mediators, so that aggravates the insulin resistance. So it is a double whammy all the time for these patients. So obviously you have to avoid overfeeding and to prevent hyperglycemia and insulin resistance. Underfeeding can accelerate the protein degradation. And what we don't always realize is a lot of obese patients can be malnourished. Not all of them are obese because they're eating lots of steak and vegetables and potatoes. They can be unhealthy and very malnourished. So the guidelines actually say hypocaloric feeding with higher protein, and that energy provision for all classes of obesity, according to indirect calorimetry, shouldn't be more than 65 to 75% of energy requirements. And as I said before, try to use ideal body weight when you actually calculate their protein requirements, because it's very high. If you do it on the actual body weight, you'll never get to that, and it's dangerous. So just miscellaneous. Infection control. Millions and millions are spent on infection control. And we still see nurses doing this, taking out the spike, unscrewing the cap of the bag or the bottle of feed where there's a foil. You're not supposed to touch the spike or the foil. And then they take this little spike and they're like, oh, just put it down. I forgot to do something. Put the bag down, come back later. Okay. And then they spike that bag. You have contaminated that bag. And then you wonder why your patient is having diarrhea 2 or 3 days later. So it's very important that when we talk about infection control, we include the enteral feeding. Everyone is aware of the aseptic techniques with parenteral nutrition, but with enteral feeding, we often forget about that. Check the position of the feeding tube. When I worked in the UK, the process of auscultation. Auscultation is where they take the feeding tube and they blow the air, and then they say, yeah, it's in the stomach. You can also blow air in the lungs and hear the same sound. How do you know that that sound is actually coming from the stomach? So the nurses still do it. I'm trying to get rid of it. It's a practice that's been banned overseas, but we still do it in South Africa. Some places use litmus paper. Litmus paper has been found to be unreliable. The gold standard is an X-ray, and daily after that, pH paper to check your position of your feeding tube. Safety and quality control measures is actually to make sure that the correct feed corresponds to the prescription that is written up, so that you don't have one feed but something else is written up for the patient. Okay. Diarrhea and constipation is a talk on its own, and it causes a lot of havoc in our units, especially diarrhea. It's difficult to treat, but I think there is a systematic process that can be followed, and there are protocols available that shows us how to deal with diarrhea in our units. Probiotics. A lot of people believe in probiotics and they give it to every single patient. There is no one size fits all. The studies is still inconclusive, different strains, different patient groups. So to routinely give probiotics to all your patients is not evidence-based. Refeeding syndrome and fat overload is my last two slides. Just quickly want to go through refeeding syndrome. So that's the occurrence of severe fluid and electrolyte shifts, especially phosphate, with metabolic consequences in your malnourished patients when feeding starts. And I can honestly say that I've been involved in 2 patients in the last 20 years that's actually passed away as a result of refeeding syndrome. So I'm very careful when it comes to refeeding syndrome. People don't often believe that it exists, but it's true and it does exist. And it's likely to occur in patients that has had long periods of nil by mouth. Not necessarily nil by mouth, but you know these patients that are on clear fluids for 3-4 days, then the surgery is postponed, then they're on clear fluids for another 2-3 days. So where there is little nutrition for 7 to 10 days. Your chronic alcoholics, your anorexia nervosa, your chronic antacid users, chronic diuretic users, or any prolonged minimal intake. Okay, so you're basically having a patient that is in a starving state. They have increased gluconeogenesis, okay, leads to protein catabolism and a negative nitrogen balance. It leads to decreasing body mass, water and mineral depletion, and adjustment to a new metabolic state. So their resting energy actually lowers. Then you start refeeding them, especially with glucose. So there's a conversion to glucose as the major energy source. It leads to insulin release. It causes intracellular glucose uptake and increased protein synthesis, and it causes intracellular shifts and extracellular depletion of your phosphate, your magnesium, and your potassium. Okay, so you get the sudden drop, and it can happen 2 or 3 days after you actually start feeding these patients. So insulin release stimulates the sodium-potassium ATPase pump, requires magnesium as a cofactor, so that's also why your magnesium will drop. This drives potassium into the cells and sodium out, and carbohydrate load, especially in your parenteral nutrition, and insulin release stimulate potassium shifts into the cells, so you get this hypophosphatemia. And phosphate depletion is associated with increased urinary magnesium excretion. So it's this whole circle that takes place and everything starts dropping. And this leads to low extracellular phosphate, magnesium and potassium, and may precipitate the symptoms of refeeding syndrome that can be very dangerous, causing cardiac, respiratory, neuromuscular, renal, hematological, hepatic and gastrointestinal complications. Fat overload syndrome is not something that a lot of people are aware of. It's patients that are actually at risk for poor lipid clearance. And this is your patients that come into the unit with hyperlipidemia, obesity, diabetes, overweight. They are septic, they are critically ill, multiple organ failure, they have renal impairment and liver disease. So the fat overload syndrome is where you actually administer excessive fat, IV, or you administer it too quickly, for example. So monitor if your patient is on parenteral nutrition and if they're on things like Diprivan, Propofol and Propaven. Now the possible symptoms of fat overload syndrome, and I don't think anyone will think that these symptoms are because you're overloading the patient on fat. but it can be pyrexia, hyperlipidemia, anemia or a bleeding tendency, hepatosplenomegaly, pulmonary problems like hypoxia or gastrointestinal disorder. And that concludes my talk, and thank you very much for listening.